I just want to introduce Reza now. So Dr. Reza Tehrani is president and CEO of MedSalt. His education includes a PhD in biomedical engineering from Columbia University, and he has dual master's degrees in biomedical engineering and computer engineering from Polytech Rensselaer Institute. He has over 20 years of experience in medical imaging, and Reza has been involved with many inventions. He has published peer-reviewed papers and books on topics within medical imaging. He has worked with several healthcare organizations, such as Columbia University Medical Center, New York University Medical Center, and Nathan Klein Institute. You may also know Reza from his volunteer roles in our chapter. So he is one of the AV team members for RLCI, as well as for the monthly meetings, for the program committee for the monthly meetings, and also for the symposium. So welcome, Reza, and I'm going to turn it over to you now. Thank you so much for being here tonight and giving us this presentation.
Thank you very much, Claudia. I appreciate the intro, and thanks to Corinne, John, and the whole PMI NJ Life Science team for hosting us tonight. Let me just share my screen. Can you see the screen, Claudia?
Yes, we can.
Okay, perfect. So hello, everyone. Thank you very much for skipping your dinner and joining us for the next 3 hours. Well, I guess Claudia is telling me it's only 45 minutes, so let's start it fast. So if you have any questions, just put in Q&A, and Patricia will read them at the end of the presentation. So we're talking about the project management of quality improvements in radiology. And let me just give you a little bit background about the radiology, especially for those people who are not part of the healthcare. So radiology is basically a medical discipline that uses medical imaging to support diagnosis and treatment of disease for humans. It's also used for animals as well. And I want to emphasize on the support part of it, because radiology is not really a clinical department per se. Request from different departments like orthopedics, neurology, oncology, and you name it. And they request a specific imaging paradigm, and the data, the patient comes and the data is sent back to requested departments. So basically, radiology creates images, creates a report for it, and then sends it to the department that requested it. Now, so that's basically there are many different imaging modalities that we have. And depending on the institutions, how big the institution is and the hospital is, pretty much most of the institutions have CT, X-ray, ultrasound, because these are on the cheaper side of the instruments. And so if you have a broken bone, you need you need to image the hard tissues like bone, you use X-ray, CT. If there's an internal disease and the imaging needs to be taken from soft tissues, those are usually MRIs used. If the doctors want to see the function of the specific organs, then we have PET, SPECT. So these different modalities are used and are available in different hospital environment and medical centers. But so basically, radiology is pretty much a backbone of most of the clinical departments. And that's the reason we have International Day of Radiology, which was actually exactly 10 days ago, to promote medical imaging. And X-ray basically was accidentally discovered by Wilhelm Röntgen when he was playing with the cathode in his lab, and suddenly he noticed a glowing on the screen nearby, and then he won the a Nobel Peace Prize, right? So just keep an eye on your screen and you might win the Nobel Peace Prize. Now we jump to the quality control and quality improvement in radiology. So the reason that I keep saying quality control and quality improvement together, because quality control, quality improvements cannot exist if there's no quality control. So we have to measure something in order to improve it. So let's jump in. The question is, everybody is now pretty much for the last 10, 15 years is talking about quality control and quality improvement in the healthcare. And the reason is basically money talks. We are talking about around $4 trillion medical expenditure in 2020 alone, and by 2030 it is expected to reach around $8 trillion. We're talking about 20% of a GDP in 2030 getting spent on healthcare alone. So that's, just do a comparison. This is twice as much as cost compared to other developed countries that they provide healthcare services. And that's basically the reason we have seen different healthcare reforms in the last 20, 30 years, and with some government policies implemented in the last 10, 15 years. And the idea is bringing a value to healthcare. If you remember, maybe 10, 15 years ago, you go to a hospital, they ask you, okay, let's have CT, X-ray, MRI, and even if you didn't need it, they still get it. So because then they get reimbursed and the money comes in. Now, if the hospitals do the same now, they're only going to be reimbursed for what the patient needed at the time. So that brings a value to patient, and the patient satisfaction is a major part of these healthcare acts. Basically improving the efficiency and effectiveness of the whole healthcare system. And the way that it's implemented are through three different avenues. The first part is through CMS, Centers for Medicare and Medicaid Services. So that's pretty much covers 25% government expenditure on healthcare. That's around $1 trillion. Now, hospitals pretty much cannot survive without that, receiving that money. Now, so there are three pillars to the CMS. One is better health for population, better care for individuals, and lower cost for improvements. And So the other way to enforce these policies are through external regulatory agencies. And these regulatory agencies, some are optional, basically. Well, they announce that it's optional to join, but if you are a member of any of these agencies, basically you have to follow their guidelines. Now, if it's a hospital, you have to have the joint committee, be member of a joint commission. So although they call it optional, then if you have to be a member of let's say the joint commission, then you have to follow their protocols and their policies. So that's how they enforce it. Now, if it's the hospital or a medical center has a radiology, then they have to be a part of the American College of Radiology member, ACR. Now that means the radiology has to follow their guidelines. The doctors have to be part of the American Board of Radiology, ABR. Now then they have to follow what the ABR recommends. And for instruments, there's FDA requirements, and instruments have to follow. So that's how the enforcement of these policies are implemented. And the last part is the internal regulatory groups. So hospitals have to have some not that they have to, most of them have some regulatory groups. Some of these committees are voluntary, but again, if you are a member of for instance, a member of the Joint Commission, they require the hospital to have a quality control plan, which means then now you have to have a quality management team to implement those plans. So for any quality control and quality improvements, the four areas that have to investigate, and these are interconnected. Basically, the first part is just the people, from any personnel, and then the other part is technology and communications. Then we have processes and procedures, and then policies and practices. So I'll just jump to the first part, the people part. This is one example of one of the hospital organizational chart. Not all the hospitals follow this, but they are very similar in this. Now we see at the top, board of directors. Basically, board of directors, and actually the reason I'm giving all this, so you know exactly who is in charge, what are the things you have to consider, and then I'll follow up with the quality control specific solutions. Now, the board of directors, basically, they're supposed to be a not-for-profit position that overseeing the CEO performance and the hospital, how the hospital is performing. And in this case, we have radiology basically falls under diagnostic services. These departments interact with each other, and we have medical staff. The medical staff report and gets hired basically directly by board of directors. Now it comes to quality quality control and quality improvement team. So we have a quality control and quality improvement team, but we're going to have Paul here. Maybe I'll ask Corinne to bring up the poll number 1. And the question is, who do you think quality control and quality improvement team should report to? So maybe we'll just give, maybe when it gets to 80% response, we can close the poll and show the result. So the question is, who do you think the quality control team reports to? CEO, Board of Directors, Director of Radiology, or Director of Diagnostic Services? And the same question for quality improvements team. Should it report to CEO, Board of Directors, Director of Radiology, or Director of Diagnostic Services on this? So Corinne, maybe if it's around 70, okay. So the poll stopped, let's look at that. So we have 50% of people say, no, I'm sorry, 35% say the quality control team should report to CEO, 20% to Board of Directors, and 30% Director of Radiology, 17% Director of Diagnostic Services. And for quality improvement team, it's more, 40% reports to CEO, 17% Board of Directors, and 26% Director of Radiology, and 20% Director of Diagnostic Services. Okay, so the best scenario is for the quality control team. Oops, sorry. The best scenario for the quality control team to report to the Board of Directors, and that's many of the hospitals do that. Those are part of the requirement for some of these external committees that I've mentioned. And the reason for that is if the Board of Directors can get unfiltered information about the health of the organization and how the CEO is performing. If it's directly reported to the CEO and the CEO reports it, it gets filtered depending on it can be modified, it can be filtered, it can be changed. So that's how the best scenario for the Board of Directors, quality controls, to report directly to the Board of Directors. In terms of the quality improvement, that's different, because for quality improvement team, they get involved with the specific department. They have to know exactly who is in the department doing what and try to trace any problems. If they might need to interact with different departments, they go, and so, but still, they're going to have the quality improvement team is going to be part of each department that basically can have their own quality improvement team. And the people, so quality improvement basically either, as I mentioned, the quality improvement team takes over the job of the specific administration, or just oversees exactly what how it's how it's being done. We have administrators, they do more on the scheduling patients. Nurses, they basically ensure patient safety and anything that needs to be done, procedures needs to be done for imaging. We have technologists that acquire images, sense the images. We have physicists to to make sure the quality and safety of the imaging devices are managed well, enough dosage, for example, for CT. And the radiologists basically are medical doctors. Now we have some local medical radiologists and some, which hospitals, they have to have one local. And the radiologist make a report, reads the images, make a report, and sends it to the department that requested it. Now, if the report comes from emergency department, it's going to be local radiologist, but for other departments, radiologists might be reading and reporting remotely, and all the images and reporting is done remotely. So that comes to technology, that we have to trace any problems or any issues that we see. And the main part, and we have basically abundance of technologies in any hospital, and they just keep growing with all these, many different tools are being developed. We have medical imaging instruments, PET, CT, MRI. We have radiology information, basically different databases for different departments. Radiology information system is specifically for radiology, patient information reporting. PACS is more on the picture archiving images that they have to keep in a storage, at least based on a policy for 10 years. They have to have it accessible based and then we have the umbrella on that for the hospital, electronic medical record, the platforms to send images, as well as reports to different organizations outside your doctor request that we need this information. So the hospital sends those information through platforms that they have. So that there are many different IT and technologies. And it's becoming more because a lot of these readings, for example, images, there are reports, it's become automated. It is automated to the extent that the guidelines allow. There's a lot of artificial intelligence for reading the images, and if they find the tumors, and then they report, and the radiologists come and they confirm if that's true or not. The report cannot be directly sent from the computer to the requested. It has to be overseen by the radiologist and confirmed, and the report is written by. Now, the third part is about processes and procedures of the radiology. And we have basically three areas. The first area is all the systems and data and the information flow. That's the one that I've shown on the left. Basically, there is on the system. This is just an example of it. I've shown there is a request that the order might come for a CT. There is a scheduling platform. A task is created. The machine captures some images. Then we have a report that has to be, the images has to be read, a report created, and it's sent to either sent or retrieved by the requested physicians. So we have all these fully IT basically related infrastructure. And then the second part of it, which is on the right, is who is doing what. We have receptionists, secretary, technologists, radiologists. So what is the job of each one in this process? And that basically changes based on where the request is coming from. So if the request might comes from the emergency department for maybe a brain or head injury, that's although might be exactly the same as someone coming from a different department, but because it's emergency, they have its own process and procedure, and they have to use a local radiologist. The report has to be sent it back as soon as possible. And these processes basically are defined specifically for, again, for case by case. And the last part that I have not shown, and it's more technical about the specific imaging modalities, that what modality has to be used, exactly what parameters to use, what organs and how to image it, in what directions. Those comes more on the physicist job that has to follow all the processes and procedures. So and the last part, which is about the policies and practices, and these are more on the guidelines that there's not much flexibility. We have national guidelines, we have ACR for academic committee of radiology. Basically every there are some internals committees that define, and then we have CMS, the Center for Medicaid and Medicare and Medicaid. They say, okay, you have to use maybe this amount of dosage for CT. You cannot increase it, you cannot decrease it, and these have to be reported directly to CMS for reimbursement. And that reimbursement varies. For example, if they follow the protocols, if they make an improvement, then they get the money. If they don't follow those protocols, if there's no quality improvement, then departments are penalized. So basically, they have to either take the cost by themselves, or it's the reduced payments. So that's how the quality, the policies and practices are implemented. Now, on the tools that we use for healthcare and in general for radiology, it's pretty much similar to or maybe identical to what you use in any other industry. We have, let's say, flowchart to analyze the occurring steps. For example, if the patient checks in, what are the processes, and try to find where the bottleneck might be. If we have, cause and effect diagram or the fishbone diagram, that's basically to identify what are the what might be the cause of the specific problems. And again, we have to consider all four areas that I previously mentioned on these on our analysis. We have SWOT analysis, basically explaining about analyzing the opportunities and shortcomings, and it is really and the SWOT analysis, it's very helpful because sometimes you can do an improvement that might cost or might not be feasible. However, either because of the policy implementation or because there is a outside governmental reward to implement those. So let's say they might get 50% from the Medicare or Medicaid, and if they implement certain things, they can get 100% or 150% over paid for that implementation. So these, you have to consider those numbers in your calculations. And we have, Pareto chart, basically analyzing the spectrum and frequency of certain events that keep happening. For example, if there is a re-exam of a same patients, how many times that it happens, are there certain days that or a specific time of the day, if it's device independent or if it's the people independent. Technologists might not be, specific technologists might not be qualified as much. So that's really the Pareto chart helps in that aspect. The other tools, for example, check sheet. We can analyze frequency of various events. For example, if we have, for certain days, specific days, if all the technologists follow all the protocols. If there is a missing, then we have the checklist will show those. We have RCA diagrams, which is really helpful. 5 whys approach, basically, try to get again all the way to the why specific the problem is occurring. Productivity chart, productivity run chart is of value because, and you really need this in any improvements, quality improvement project, because you have to keep checking to see, are you improving of what it used to be? So you have to have some measurements of the problem. You can compare it with the external, you can compare it basically maybe different devices, how they are performing, and with the outside, maybe in other institutions, performance for a specific device or a specific technologist. And we have statistical process control chart, which basically you can see over time how you are doing. Are you, is the improvements that you are making or you're proposing, is it staying over time, or is it just coming down? Now, so with all these tools, we come up with a list of projects that needs to be implemented. Let's say here now I have on the left, a dozen of them. It doesn't matter what it says, it's small, but it doesn't matter. It's any project that this is specifically for healthcare, but it can be used exactly the same idea can be used for any industry, especially because this is slightly modified project prioritization matrix. It's made it as a 3-dimensional, and it's made it 3-dimensional because one important factor here is patient safety. So that's basically our, if you call it the vision and mission of the healthcare, it's patient safety. So that is of great value. So that's basically 1 dimension of a 3-dimension decision-making process. And again, you can use that in your industry and change it and adapt it based on what is important in your institution or in your project. The other part, which is similar, is the measuring the impact. The impact of a project, basically, it's the average of. Actually, let me just back off a little bit. Patient safety. We have for every project. Let's say we have a dozen here. We have to rank it from 1 to 10. If it's improves the patient's safety, if it becomes 10. If it doesn't have any effect on patient's safety, then it's 1. And you basically score every project and you get the patient safety effect on that project. Then we have the financial impact. Does the does implementing that project have a significantly changes the how the basically how much money comes to the institution. Then we have referring clinical satisfaction. And the reason that's very important is, as mentioned, radiology is really a service department. It's a support department. So if they are not doing a good job, if their reports are not well written, if the images that are sent to the requested physicians are not good quality, they then they are not going to get those. They are not going to get requests from those physicians. Now we score basically for every project. We ask all the referring physicians if what is their satisfactions would be. So we score that again from 1 to 10. 1 would be the worst, and 10 would be the best satisfaction. Patient experience satisfaction, that's really important, especially because of all the Affordable Care Act and the other policies, because up to now, maybe until maybe 15 years ago, nobody even cared if you can find a parking by the hospital or not. Now suddenly hospitals have to think in every aspect how they can satisfy patients. Now the reimbursement basically is based on how satisfied the customer is. If the customers are not satisfied in the large populations, the calculations, then there is a much lower score here. And if we have, and the most important part of any project is if there is a project leader, if there is someone that is really stakeholder priority for the medical doctors, we have to implement that. Then we find those numbers, we average them, that becomes total impact. And then we have how long does it take to implement a project? In terms of, I'm now measuring the feasibility of a project. How long does it take to implement a project? If it's a long time, that becomes 10. If it's and every project costs money. If it's a little bit money, it becomes 1, and if it's the high, it becomes 10, and or any numbers between. The process changes. How many of the, if you want to implement the project and you have to change 10 or 15 different processes, or if you have to make a lot of get other departments involved and make changes on those on those departments as well, so that becomes higher. It becomes less. It becomes less feasible, or can't say less visible. It becomes harder to implement those projects. So we give higher numbers. If it involves IT systems from different databases and different platforms that all have to be changed, then now we have these 3 parameters. Let's now I'm just going to talk about the first 2 about feasibility and impact, and then I'll mention next slide, bringing the 3rd dimension. So the feasibility here we have, if it's easy to implement, it comes all on the y-axis up there, and if it's very hard to implement or a heavy project require multiple departments involvement, then it becomes a heavier lift, it becomes a 10. Now, from the right left also we have the impact. So the projects, for example, that you do, it doesn't impact significantly So that's on the left side, and the more impact the project has, it goes to the right side. Now, the third dimension that I talk about is the impact on, for example, on patient safety. Here we have shown them with how big the circle is. So the bigger the circle is, the higher the safety, the impact on patient safety. Again, you can modify it and put for your industry what is most important for a vision and mission of that industry or that project or that company. So we have, let's say, project 1, 2, and 3. They have almost similar feasibilities, but project 1 is very easy. It has a little impact, but it's very easy to implement with, just a small modification. So we give this one to the project 1. Then between project 2 and 3, they have significant impact because they have moved all the way to the right. However, project 2 has a lot more impact on safety, so that automatically gives higher priority to implement that project, and so on. So we could go, and basically the project 8, it has extreme amount of effort with little impact. So that's basically, it's one of the projects that once you get involved, you are finishing fast because the project is going to get cut and it's not going to be funded. So now we have in order to implement it, so the most part of it, we need a project sponsor. And we need project sponsors on any healthcare or medical institutions. It becomes extremely important. It's because it's extremely difficult to implement any improvements in radiology or in general in healthcare organizations. And the reason is they are designed to be stable and endure many different challenges. Now you want to make changes, it's going to be hard. So you definitely need a project sponsor. When you need it to go to another department to implement it, you have that sponsor to enforce that and to get the permissions. Project leader, basically, and the project sponsor and project leaders are always part of the institution and healthcare. They are usually medical doctors with a passion to solve specific problems, and they are of great value because if they are not, there's not going to be a significant change, or even if the project gets implemented, it's going to be a minor effect to the organization itself. And the project participants and project coach, basically, those are the people who implement it. They are a lot of them, project participants are the consultants and the people with expertise, and the project coach kind of to keep the team. So these can be externals, and the first two basically have to be internal to the institution to make the project viable. Now we have we have achieved the quality improvement that we promised. The project worked. Now we basically handed the project to the from the improvement team. It's handed to the operations team. So, as I mentioned, because of the way the project of the institution, it's not going to survive unless we have continuous measurements and reporting to the higher authorities so that the operations team to make sure the operations teams follows those. And at that point, if they see there is any discrepancy or going back to the old model before the improvements, they can try to stop that. And I'm basically done with the presentation. Claudia, I think I am pretty much on time as I promised. It's 7:50. Maybe we can have some questions. Patricia.
Okay, Reza, yes. The first question is from Anna. Is quality improvement by external, non-affiliated entity, non-biased entity?
So the question is if quality improvement by external or non-biased entity. Well, you cannot really say if they are non-biased because they are trying to implement what they have developed. Is that a good fit to the institution, and is that the need for the institution or for a hospital to have it? If that's the need, that's good. But here we have the quality control team, which is not reporting to the CEO, oversees the implementation. So they are basically unbiased, well, as much as possible to oversee it. And so it can, so it depends case by case.
Okay. So are you finished answering that question?
Yes.
Okay, can I move on to the next? Okay, here's
sure.
The next one is from Hotmail. Do the regulatory agencies get constant feedback from the radiology community to establish and, more importantly, update regulatory guidelines? How is this incorporated into quality improvement process at the facilities using radiology?
Yes, they do. And for example, CMS, the Center for Medicare and Medicaid, they have come up with 23 parameters that radiology departments have to report back to CMS for reimbursement. These parameters related to different medical imaging some of them related to the dosage, some of them related to re-examinations. So they have to report back to the agency. And if there is no improvement on those, then it's going to be a reduction on the institution reimbursement. Again, the way that the Affordable Care Act is implemented is they reward the institutions that do a great job on certain on the defined parameters and the quality and efficiency, and they penalize for the not following those guidelines. So, it's about money, and institutions cannot, healthcare, medical, they cannot survive without money. So they have to follow those rules and guidelines. And doesn't mean that it's exceptions doesn't happen, but it's in the, and we're talking about the healthcare it's probably one of the last industries that hasn't reformed just because of the way that it's designed for its stability. It takes a long time to implement. We're talking about last 10, 15 years. The effect of it is now, and probably we're going to see those reforms for the next 10, 15 years in order to come to some balance and the best processes and procedures. And the other part that I'd like to mention is all these data from all different institutions are coming together, and if the decision used to be made by a doctor that has seen maybe 5,000 patients throughout his or her life, now suddenly we have access to outcome of a certain procedures on 200 million, 500 million people throughout the world. Now it's a lot more valuable. So that's also a big part of it. And these improvements, these are smaller improvements that we make. And then in the long run, there is going to be a lot more quality improvements. Again, it's going to be small improvements piece by piece for the next 10, 15 years to go.
Okay, this question is from Matt. Can you describe what kinds of change management activities you do to ensure adoption and success given institutions' resistance to change?
So that comes to quality improvement team is the quality improvement team is not really. Oops, I think we have echo from. Quality improvement teams are not implementing any change management. That's the department's job and the department's position to do. The change, the quality management team proposes, implements, and gives those to operational team. Now, if those part of it, if it requires a change management, that comes back to quality control team to implement it, or and that's basically to the department, for example, in this case, radiology department. First, it's going to be through radiology department, but if it goes to, if it affects the other departments that they have to make changes, that goes through the quality control and through sponsor. Again, medical and healthcare related changes, you really need to have a strong from the top, strong sponsors and team leaders from the top, medical doctors, that they cannot just change. And if you don't have these change management, you implement something and it's going to change back to what it was, or it's going to be unsuccessful. That is the only difficulty we have on the healthcare related medical, and that's again the reason that healthcare has been the last industry to reform itself.
Okay, I'm not sure if this will be the last question, but let's see. From Kevin, are imaging tracers considered drugs? I'm referring to the radiopharmaceutical injected into the body. I have seen a recent court case where FDA was overturned on this issue. Yet I'm working with imaging tracers suppliers who are referring to their INDS or NDAS investigations, new drug application or new drug application.
I'm not sure about the wording if it's considered drugs or not, but it has to be, the tracers have to be injected, for example, for a CT or even for MRI with contrast. There are different, sure, you can actually call it drugs. There is an injection, well, we usually call it contrast. There is an injection contrast, and some people have bad reactions to certain contrasts. And FDA might approve one based on the information that it has at the time. For example, if the drug or contrast has to be tested, I know, in 5,000 people, there's no reaction, but suddenly once you have it on a 10,000 or maybe 500,000 people, there are some cases. So it's also hard for FDA to know everything. So that means FDA cannot predict how a specific. They get the minimum required that is viable for any for any test, for any drug or contrast to be tested. They cannot test it on. If they test it on 500,000 people, then it's not testing anymore. So FDA, FDA does make changes over time, and they might recommend some at some point. I remembered one that was for MRI, and at some point around 10, 15 years ago, and they changed and modified that contrast, or they make the company to modify the contrast to something that was less problems for people with which had issues with that specific type of contrast. Do we have time?
Yeah, it's 7:59. Do you want to take another question, or do you want to call it quits?
How about we'll go maybe for one more? It's 8 p.m. Let's go one more person, okay, and then I'll be fast.
Okay, this is a short one. What is the average turnaround time from ideation to delivery of an improvement project in radiology?
And that depends on where it stands on the prioritization graph that I showed. If it's the small project, you can have it, if it's a small, and a lot of institutions actually like those projects because it doesn't affect and doesn't make a bottleneck for them. Let's say improving the patient waiting in a waiting areas. That can be implemented without interfering with the devices. They can track. Some of the form filling out the forms can be done remotely. They can basically do a better management of scheduling, and these can be read basically through as a part of the quality control and quality improvement. These are the data that's available on different platforms. For example, when the patients come into the hospital, to the radiology department, they have to register. Now, the time that they start getting the MRI, that's the stamp on MRI itself. So these informations that are available, and it gets automatically reported to the quality control department. And these are easy to implement without much interruptions to the institution or to the hospital.
Thank you very much, Reza, for such a wonderful presentation. Thank you for your time, and I've seen a lot of good comments in the chat section that people really did enjoy this presentation. Thanks a lot to everyone who attended the presentation, and thank you for your support to the Life Science Group, and have a good evening, everyone. Thank you.
Thank you very much, Patricia and the team, for having me. Have a good night. Have a great night.
Thank you all. Wishing everybody wonderful holidays. Thank you so much for coming out tonight. We are actively planning our 2022 program, so please keep an eye on the website. Again, happy holidays. Thank you so much for coming.